Good morning, everyone. At the outset, I thank the organizers for giving me this opportunity. So, after the talks on the KRAS testing and KRAS inhibitors, we go on to the next step. What we should do if there's a resistance to KRAS TKI? So, KRAS mutation is one of the most prevalent oncologic alteration and is the first oncogene which has been discussed in the lung cancer. The KRAS inhibitors, which has been approved as sotorasib and adagrasib, as discussed already, and there are phase 1-2 trials which have shown a promising anti-tumor activity against it. There are several the primary and secondary resistance to KRAS inhibitors has been known, and there are several mechanisms of resistance which are intrinsic or which can be acquired. I'll be discussing about this resistance in the next slides. So, given the efficacy of the KRAS inhibitors, but these inhibitors have considerable proportion of patients may not experience a good tumor response, and few of the patients may progress on this treatment because of the acquired resistance. About 10% of the patients would have a primary intrinsic resistance to the KRAS inhibitors. About half of the patients which have been included in the trials with adagrasib and sotorasib have experienced acquired resistance to the KRAS inhibitors. So this is the landmark trial, the phase 1b/2 trial, looking at the sotorasib in NSCLC, 40% tumor response rate, and adagrasib showing around 40% response rate and a disease control rate of around 70%. So what are the mechanisms of resistance? This is the diagram showing various mechanisms of resistance. There are different downstream and upstream pathways involved in mechanism of resistance for the KRAS inhibitors. Now, we divide the resistance into two types. One is the intrinsic or the primary resistance mechanism. It is mainly by the two main downstream effectors, that is ERK and AKT. There is an alternative PI3K AKT activation pathway, which can be due to the oncogenic mutations in the AKT1, AKT2, PIK3CA, and PTN. There could be RTK, that is tyrosine kinase inhibitors. Upstream activation is one of the critical mechanisms in the KRAS inhibitors resistance. Now, there are acquired resistance mechanism, which can be divided into two types, that is on-target mechanism and off-target mechanism. Now, what is on-target mechanism? It is acquisition of the mutation within the driver protein that impedes drug binding or target inhibition. There are various secondary KRAS mutations, which I have enumerated there, and the most common being and most prominent being the Y96D mutation, which lead to the mutation at a relevant position for sotorasib and adagrasib binding. And this has been studied in the Crystal-1 study also, where they found that this mutation has been a prominent mutation in the treatment of the KRAS inhibitors. These are the on-target mutations which I've enumerated. Now, what is the off-target mechanism? Now, off-target mechanism is a biological alteration which is independent of the KRAS inhibition. Now, the two important pathways or canonical pathways involved are the BRAF-MEK ERK pathway and the PI3K AKT mTOR pathway. It can be also because of the MET amplification, which confers resistance to the TKIs by the activation of the MET pathway. It can be because of the rate kinase domain mutation leading to the oncogenic signaling of the BRAF-MEK ERK pathway. It could be point mutation and deletion in the MAPK pathway effectors. It can be also because of the BRAF V600E mutation, which can develop ongoing on those patients who are on KRAS inhibitors, leading to the resistance to the KRAS inhibitors. And it can also be because of the histologic transformation, where the adenocarcinoma cells can sort of mutate to can differentiate to squamous carcinoma cells, leading to the resistance, as we have seen in the EGFR inhibitors. Now, what are the therapeutic strategies for the KRAS resistance? Now, the KRAS resistance has been a more difficult way to understand it. What are the testing to understand this KRAS inhibitors, which mechanism of resistance is playing a role, has not been that greatly elucidated in the terms of the testing pathways. And so the finding the therapeutic strategies has been a challenge. One of the things they have tried is combining the sotorasib with MET inhibitors such as crizotinib and carfentanib, and the other have been in those patients where there is a BRAF V600E mutation, we can combine dabrafenib plus trametinib to overcome this resistance. There are different trials which are looking at the novel drug strategies, like the phase 1-2 Crystal trial is looking at combining the novel drug with sotorasib There's a phase 1b2 trial looking at the other novel drugs with sotorasib again. There are other ways of combining the KRAS inhibitors with PI3K AKT inhibitors, combining KRAS inhibitors with chemotherapy, or combining KRAS inhibitors with CDK4/6 inhibitors. There's one more interesting thing. Whenever there is a cell death induced by the KRAS inhibitors, there is a pro-inflammatory microenvironment that is developed, and that leads to the ground of usage of immunotherapy along with KRAS inhibitors. So the multi-arm Codebreak 101 trial is looking at combining the sotorasib plus immunotherapy, that is pembrolizumab, or sotorasib plus atezolizumab. There's a phase 2 Crystal 7 trial which is looking at combining the adagrasib with pembrolizumab. So interesting times ahead in those patients who have mutated KRAS. Those who have developed a resistance to KRAS inhibitors, we have something to add on. But again, in conclusion, the biological mechanism is difficult to understand for the KRAS inhibitors which have developed the resistance. The resistance to KRAS inhibitors is not totally understood. There are different pathways which might be further involved, and we require more and more data to come in. As we discussed, there are different mechanisms of resistance, which can be intrinsic resistance or it can be an acquired resistance. And we need further testing methods to understand what is the mechanism of resistance and more drugs to come in so that we develop a therapeutic strategy in those patients which have developed resistance to KRAS inhibitors. Thank you.
Thank you, Dr. Pritam. And now we are moving to the next session, which is dedicated to KRAS mutations. And I would like to invite Dr.